No, sir.
No.
No, sir.
Have you given anesthesia for tonsillectomy?
Yes, sir.
You have
Yes,
given
sir. Anesthesia. Yes, sir.
Yes, you have given anesthesia for tonsil. So your surgeons are very good and your patients are very good. So they didn't give you the complication of post-tonsillectomy bleeding. And this is a complication which happens in a large volume centers where, in Madras Medical College, GH, in the summertime, they used to operate 30 to 35 tonsillectomies in a day during school holidays time, especially the summer school holidays time. There will be minimum 35 cases per day by each ENT surgeon. And because the operating surgeons are not all the time seniors, even the postgraduates, ENT postgraduates also will be given training. So some of them might miss out on proper hemostasis, and this problem is more common in large volume centers. Okay. So if you are still having problem with connection.
Sir, good evening, sir.
Good evening. Are you ready, ma'am?
Yes, sir. Yes.
We finish this topic first and then go ahead.
Okay, sir.
Now can you just read out the case scenario given?
Sir. 4-year-old male child who's bleeding after 4 hours of adenotonsillectomy management, sir.
Okay. So in order to make it visually impressive, I have prepared a set of questionnaire. And
Yes,
I will
sir.
show you that because this is not a real case discussion like what you are going to face in the Viva.
Okay,
I thought
sir.
with the case scenario cases, it will be better to have a question answer session. So
Yes.
I will just share my screen and I will show you the questions that you have to answer.
Yes, sir.
Is the screen visible?
Yes, sir. Visible, sir.
Okay. So the case scenario, for those who have not had the chance to see the link sent earlier, a 4-year-old child, male child, gets operated for adenotonsillectomy. And it has been successfully operated and sent to the post-operative ward. But 4 hours later, there is a frantic call from the post-op unit saying that there is some bleeding going on and patient is restless and not doing well. So this is a common case scenario that may be given both in your theory clinical paper, that is third paper, or it can be given as a case scenario basis for discussion, because an acutely bleeding patient cannot be brought for live discussion. So it will be only a case scenario. So the first question that we have to ask is, what are the challenges in this case, Vidya?
Sir, as usual, the general consideration, as since it is a pediatric case,
Very good.
they're more prone for hypoxia, hypothermia, and difficult IV access and difficult airway.
Okay.
In addition to that, since the baby had previous intubation, previous anesthesia and surgery, the intubation and the baby will be more dehydrated and hypovolemia. The IV access and airway will be more difficult than usual, sir.
Very good.
Because of bleeding, the baby will be hypovolemic, tachycardic, hemodynamically unstable, sir.
Very good.
And there is risk of aspiration since there is a lot of bleeding, and if there were increased bleeding, the baby would have swallowed the bleeding, and the stomach will be more distended. And also post-surgery, they might have initiated oral feeding, which also
add
has
to
the
the
risk
stomach
of
volume.
aspiration.
Very
Yes,
good.
sir.
Anything else? You have said 3 points. The
Yes,
first
sir.
point is a pediatric age group patient with the challenges of pediatric anesthesia.
Yes,
So
sir.
the pediatric anesthesia challenges are always classified as different anatomical nature of the child. Okay, their airway is different, their body mass index is different, their autonomic nervous system abilities is different, their blood volume is always higher than blood volume of an adult, so they become hypovolemic much more faster. Their temperature regulation is also very difficult. More than that, a 4-year-old child will have separation anxiety or stranger anxiety. That is a very important thing.
Yes.
Even for an elective surgery, when it comes for the surgical procedure to the OT, it will be clinging to the mother. So unless you give proper sedation or do some pre-induction sedation of the baby, it is difficult to separate it from the mother and take it inside. So the stranger anxiety will happen beyond the age of 6 months. So these are all, and having had a surgery just 4 hours before and after developing a problem like this, the child will be more anxious and more restless and may not cooperate. So that is the first problem. The second problem is we do not know the assessment of blood loss in post-tonsillectomy bleed is very, very difficult because part of it will be spat out, part of it will be swallowed. So the total quantum of blood that has been lost will not be easily calculated. So what are all the signs that there is a heavy loss in this child?
So initially there will be tachycardia
Hmm.
and decrease in the capillary refilling time.
Increase or decrease? Capillary refill time, will it increase or decrease?
Increased, sir. Increased, sir.
Increase. What is the normal capillary refill time?
It is less than 2 seconds, 2 to 3
Less than 2
seconds.
seconds. So supposing it becomes 4 seconds or 5 seconds, what does it mean?
Reduced perfusion.
Reduced peripheral perfusion. So there is lesser blood flow to the periphery. So the child has messed up. And the blood pressure and respiratory rate, will it alter if there is a severe hemorrhage?
There will be tachypnea, increased in the respiratory rates.
The body tries to
Because of
compensate by increasing the respiratory rate to take more oxygen in because the carrying capacity is decreased. So
Yes.
tachypnea, tachycardia, feeble pulse, increased capillary refill time, dryness of the tongue. Of course, here with the bleeding, we cannot assess the dryness of the tongue. Okay.
Yes.
So all these things will tell you that the child is lost considerable amount of blood. So that is a very important clinical examination we have to do in the preoperative phase to correct that hemodynamic status before inducing anesthesia. Supposing the surgeon is pressurizing you that we have to take up the child immediately and arrest the bleeding. What is the risk in taking up a child who has had a considerable hemorrhage and who is hemodynamically compromised?
There is more
Supposing
chance
you
of
take up the
cardiovascular.
child at a pulse rate of 160, a BP of 70/40, you go and induce the child, what can happen to the child?
Cardiovascular collapse and will lead to a cardiac arrest.
Cardiac arrest. Because already the child will be in a state of severe vasoconstriction to maintain the blood pressure. All our anesthetic agents try to do vasodilatation. So there will be a profound vasodilatation, and with the inadequate circulating volume, there will be a acute profound fall in blood pressure, and patient may even arrest on the table. So the first thing you have to do is resuscitate the patient adequately before taking up the child for exploration and control of the hemorrhage. And the third possibility, what you said, is a full stomach due to swallowing of blood and chances of vomiting and aspiration during induction and intubation. And the fourth thing is challenging laryngoscopy and intubation because of blood in the oral cavity and edema of the soft tissues because child has been recently operated. Your visualization of the vocal cords and larynx may be quite challenging in this scenario. So these are the common challenges. And it is a shared airway between the surgeon and the anesthesiologist. So once you have intubated, the ET tube could migrate, kink, and get compressed. So these are the 5 challenges that you have to describe in your answer, whether it is a theory question or whether it is your practical exam, you have to do that. The second question is, what relevant information is needed during pre-op evaluation of this patient? What are all the information you would like to get from
We have to
the
first clinically look into the patient, how bad the child is, and then we have to look the previous anesthesia chart.
okay.
What were the drugs given? What was the ET tube size chose? And and when was the baby had his last meal?
So 4 hours after surgery, now they would not have fed the baby anything solid. You could have at the most had some sips of liquids. Okay. So,
Yes,
but oral intake, you should term that as oral intake and not as last meal, because
okay,
nobody
sir.
will give a solid or semi-solid meal within 4 hours of surgery. So, when was the last intake? Oral intake. That will be a better way of questioning. And of
Okay,
course,
sir.
you have to clinically see the child. But so how to assess the hemodynamic status here? Because we have seen that by looking at the pulse rate, blood pressure, capillary refill time, peripheral temperatures. The peripheries may become cold and clammy if the blood volume are lost to be quite heavy. And you can send the blood for assessing the hemoglobin and other parameters immediately. Now, what details you need from the previous anesthesia chart, which you have already said about the size of the ET tube used, the route of intubation, because it
Yes.
is an adenotonsillectomy, as it is given in the question. What is the preferred route of intubation for adenoid removal and tonsil removal?
For adenoid, it is oral route.
If it is a combined adenoidectomy and tonsillectomy, the surgeons prefer to have the oral intubation. What is the tube that you would like to use for oral intubation for adenotonsillectomy?
Sir, south-facing tubes.
The oral ray or south pole tube will be a better tube which can be accommodated under the blade of the mouth gag. So that is the preferred tube.
Yes.
If only tonsillectomy is that surgery planned, what will be the route of intubation?
A nasal route is preferred.
Nasal route will be the route of intubation. So from the anesthesia chart, you must not only find out what the tube was used, but also the route of intubation, whether it was nasal or oral. And
Whether the intubation was difficult and size of tube used.
whether there was any challenges in the intubation during the first attempt, and whether the what are all the drugs being used for induction, whether it was a spontaneous respiration or whether it was controlled respiration for the entire procedure, and if controlled respiration was adequate reversal of the neuromuscular blocking agents done. So all these things, and what was the behavior of the child during the previous anesthesia, hemodynamically, oxygenation wise, removal of carbon dioxide wise, all those things you have to look into the chart and make a assessment, so that you can know whether the child behaved properly. And if supposing they have used Stolin for intubation, some anesthetists, especially in those days when we were postgraduates, for tonsillectomy or adenoidectomy, we were taught to induce the child with thiopentone, give dexamethasone, intubate the baby or the patient, and then assist the ventilation till they regain spontaneous respiration. Before that, the surgeon would put the mouth gag and start operating. And by the time the patient regains spontaneous respiration, one side would have been completed, and we always leave the baby or the patient on spontaneous respiration. And at the end of the surgery, we cut off the volatile anesthetic agent, recover the child, because we don't have to give any reversal or anything. And once the good cough reflex is there, we used to extubate the baby. That was the procedure or the method that adopted. So, but current days, the teaching is to go for controlled ventilation, even though it depends on the surgeon's timing. If he's a very fast surgeon who can finish the surgery within 15-20 minutes, There's no point in paralyzing and then taking over the ventilation and waiting for the child to recover and get back the spontaneous ventilation, especially in, as I said, in a heavy list with 20-25 cases. It is not possible to do control ventilation in all cases. So in such cases, choline may be the choice of relaxant for intubation. So what are the problems that you can face if you use choline for intubation? What are the disadvantages? Choline, of course, is a very good agent to give complete paralysis, and ease of intubation is very good with choline. But what are all the challenges or difficulties with choline that can arise? It's one of the questions that may be asked in the Viva exam. Nowadays, most of you have stopped using choline, isn't it? Majority of the GAs, you are all trained to straight away give a non-depolarizing muscle relaxant and go for intubation. So you must have a correct concept about use of choline, succinylcholine also. So can you name a few complications that can be produced by succinylcholine?
Sir, myalgia, hyperkalemia, increased in the intra-abdominal and intraocular pressure,
Radical.
malignant hypothermia.
Can be stimulating. First and foremost is post-op myalgia. Okay.
Yes, sir.
The choline-induced myalgia is the most important, especially in the adults. If you are using it as a daycare procedure, early ambulation produces myalgic pains because of the fasciculation. So that is the first and foremost complication. The second is if the patient has already raised his potassium, it may cause further rise and hyperkalemia, and it may cause it may trigger malignant hyperthermia, and rarely choline apnea may be a problem, especially some communities in Tamil Nadu. The Vaisya Chettiars are supposed to be very sensitive to the choline because they do not have the cholinesterase enzyme. Normal cholinesterase enzymes are not present in them. So they may have a prolonged apnea, which is called the succinylcholine apnea. And they may ask you about how to manage succinylcholine apnea. Any ideas? I see Soundarya's face now. How do you manage a succinylcholine apnea?
Ventilate the patient, sir.
Ventilate with what? It may take 6 hours, 8 hours to come out of the choline. So ventilate with what? Because once you finish the surgery, patient is going to be out of all the anesthetic agents. So post-op ventilation for choline apnea, how do you maintain? Patient will regain consciousness, but they will be paralyzed.
Paralyzed.
So what do you do?
Post-op elective ventilation for volume control mode, I will keep, sir.
No, my question is, patient will regain consciousness after the surgery is over. Sedated. Patient should be sedated. Okay, otherwise they will be awake and they will be paralyzed. Even though you are ventilating them, they will have the sensation of paralysis and being awake. That will cause a constant stimulation of catecholamines, and tachycardia and hypertension will happen. So till the patient regains spontaneous neuromuscular activity, you have to sedate them and ventilate them. That is a very important point. You cannot just ventilate them with air oxygen mixture alone, because all the effect of anesthetic agents would have been worn off. The patient will regain consciousness. And because they are paralyzed, they cannot exhibit it in any other form except for producing a catecholamines release and stress. So you have to remember that. And what is there any way to hasten recovery from choline apnea? Ventilation and patient waiting is the answer for the spontaneous recovery from choline apnea. But is there any way we can hasten or make it faster for recovery? Am I audible?
Yes, sir.
Yes, sir. We can increase the volume load so that
volume load. So that
FFP
what is the
also
problem
helps.
in choline apnea? The drug is not metabolized.
Deficiency in the
Isn't it?
plasma cholinesterase.
There is a deficiency of plasma cholinesterase, which is the drug, which is the enzyme which is going to degrade the choline. Okay. So can you replace that? Can you artificially
Yes,
inject
sir.
that?
Yes, sir.
Fresh frozen plasma.
Component of the blood will have that.
By transfusing fresh frozen plasma.
FFP transfusion will help to hasten the recovery because it will supply the normal. So if anybody has a compatible blood group and you take the FFP from them and inject that, that patient may come out of choline apnea much more faster. Okay.
Yes, sir.
So what the third question is, what are all the features of shock due to hemorrhage that we have seen? Then coming to the next question, how do you resuscitate the child from shock before proceeding with the next anesthesia, and what precautions do you take for the next anesthesia for exploration?
So we have to secure 2 white core IV lines, and we should start resuscitating before even before shifting the baby to the theater, sir. So initially we have to give 20 ml per kg of crystalloids, and then we can titrate it by clinical improvements.
Okay.
Then
So it is
side by
a
side,
loss of blood. Children, do they get resuscitated with fluids alone?
side by side, we have to assess the hemoglobin level and the coagulation profile, and we have to transfuse accordingly.
Yes, you must immediately alert the blood bank and keep blood ready, both for resuscitation and for further exploration during the next anesthetic procedure. Okay, that is a very important thing. If blood grouping and cross matching has not been done earlier, you have to do the grouping and cross matching and alert the blood bank to provide adequate blood, because children, they do not tolerate blood loss and they cannot be resuscitated adequately with fluids alone like a adult patient. So you have to keep blood ready and transfuse the volume. What about the full stomach? How will you manage the full stomach? Because they have swallowed the blood.
Sir, we have to keep the baby in the recovery position.
Child is now fully conscious and alert. Will it lie in the recovery position? That to a 4-year-old child who is having bleeding, which is coming through the nostrils and mouth, child will be crying all the time. Is it possible to put the child in recovery position?
No, sir.
Do you want to empty the stomach, or
Kinetics.
do you want to proceed without emptying the stomach? That is the question.
We can give
Without-
prokinetic
we can-
antiemetics.
Prokinetic like metoclopramide.
Metoclopramide.
More than that, it is if the suspicion of large quantities of blood having been swallowed is there, it is better to put a stomach tube and aspirate. Okay, even though the child may not cooperate, you have to restrain and put a stomach tube and aspirate the blood as much as possible. Otherwise, you have to plan for a rapid sequence induction. Okay? So that is the answer that you have to give for that. And how to prepare the OT and how to anesthetize child for exploration. What are all the preparations you have to do in the OT before you shift the baby to the theater for the
Keep the
exploration?
OT warm, and we have
Very
to
good.
make the difficult airway cot ready with
Excellent.
the tube with the tube of same size and 0.5 to 1 millimeter smaller than the tube we used earlier.
One size smaller, not
One
the
size
0.5 1 millimeter.
Yes,
One
sir.
size smaller tube.
And the correct size
Most
working.
important thing, first after the warm atmosphere or ambience, what is the next important thing you will check?
Working suctions.
How many sections you want?
Two younger suctions.
That is a very important point. That is what the examiners expect out of you, because there is a blood clot. One section only if you have, that may get blocked. Okay, so you must have another spare section, working section ready, so that even if your first section gets blocked, you can start using the second one by the time somebody can clear the block and get the other section ready. So make sure that you have 2 working suction apparatus and 2 working laryngoscopes. Because of the blood, the light may get smudged. Okay, so
Yes,
you
sir.
must have 2 suction apparatus with the proper size suction catheters, as well as 2 working laryngoscopes. These are that is why the specific question how to prepare OT.
Yes, sir.
And then make sure that all the monitors can be connected right that as soon as the baby is brought in. And what is the method of induction you would like to do?
Sir, I would prefer
Inhalation
rapid
induction
sequence
or IV
induction.
induction? Hmm?
Rapid sequence induction with
So it is
intravenous.
induction can be intravenous or inhalational. So being a baby, you can do both intravenous and inhalation, but in the presence of continuous oozing of blood from the mouth and nose, inhalation induction is more messy.
Yes, sir.
So you can go for intravenous induction
Intravenous
with rapid sequence induction. What is the preferred induction agent of choice? The
Sir,
patient whom you have resuscitated from a shock with fluids and blood and brought to the OT. What is the drug of choice for induction?
sir, etomidate or ketofols.
Etomidate or
I would
ketoprol?
prefer etomidate. Yes.
Don't say propofol alone because propofol will cause a
Hypotension.
depression and cause a hypotension. So it is preferred to use a etomidate, or you can use a combination of ketamine and propofol, which is called ketofol, which will maintain hemodynamic stability. And will you use dexamethasone or some other agent?
Sir,
What are the relaxant of choice for
we are using
intubation?
rocuroniums. Succinylcholine or rocuroniums.
Yes, you can choose between succinylcholine and rocuronium. So if the patient has any family history of dexamethasone apnea or malignant hypertension, then better to avoid dexamethasone and go for what is the dose of rocuronium for rapid sequence induction?
Sir,
Rocuronium, is it a single dose
milligram.
drug or multiple dose drugs?
1.2 milligram per kg.
For faster action, you have to give 1.2 milligram per kg. For smaller regular elective induction in a faster patient, you can use 0.6 to 0.8 milligram per kg. Okay. So if you want to achieve a faster onset of muscle paralysis, you have to use 1.2 milligram per kg of rocuronium, which will be equivalent to dexamethasone in producing a muscle relaxation. Which is the preferred route of intubation here?
oral routes.
Yes, always, even though the child has undergone tonsillectomy, never try to intubate nasally. Even if the surgeon is asking you for nasal intubation, you should never intubate nasally a child who had had an adenotonsillectomy, because the nasopharynx will be quite raw and you will cause more bleeding by trying to intubate through the nasal route. So it is always a oral route. Will you use a cuff tube or a plain tube?
Cuff tube is preferred to prevent aspirations.
Aspiration. So here, even if they have used a plain tube in the first anesthesia, it is preferable that you have used a oral tube for the second exploration anesthesia, so that you can isolate the airway better and prevent an aspiration. The next question is, what is the difference between primary and secondary tonsillar bleed?
So primary tonsillar bleed, which occurs within 24 hours of surgeries.
Very good.
Secondary tonsillar bleed will occur between 24 hours to 28 days post-ops.
Post-operatively. So this bleed after 4 hours is called primary or secondary bleed?
Primary tonsillar bleeds.
Primary bleed. So what is the blood supply to the tonsil?
It is supplied by the external carotid artery and the
Straight external carotid artery or branches of the carotid artery?
branches of external carotid arteries.
What are the names?
Sir, ascending palatine artery and ascending pharyngeal artery, branches of facial artery like lingual artery.
Branches from lingual and facial artery. Tonsillar branches of facial and lingual artery. descending palatine artery and trapezial artery. Okay, right. What are the risk factors for post-tonsillectomy bleed? Can you predict whether a child will have post-tonsillectomy bleed?
So
By
risk
using
factors
tonsil-
are if it is a male child and if it is of higher age, and if the technique used is hard tonsillectomy, where the diathermy and cautery were used, and a baby with a history of a recurrent tonsillitis with peritonsillar abscess.
All these cases are more prone for post-tonsillectomy bleed. What is laser tonsillectomy and what are the advantages and disadvantages? Have you ever heard or seen a laser tonsillectomy bleeding? I mean, tonsillectomy being done?
No, sir.
No. So this is one of the current techniques that are being used. They use carbon dioxide laser to dissect because that will cause very, very minimal bleeding. It will coagulate all the blood vessels while the dissection is going on. But you require a special apparatus, the special endotracheal tube for intubation. Laser fire resistant tubes are to be used. You have to have a designated laser theater. Laser surgery and anesthesia by itself is a vast topic. So sometimes the examiners may ask you about it. So the advantage is very, very minimal bleeding. Disadvantage, it is quite expensive. It requires a separate setup. And it also, if laser fire occurs, it will be a disaster. So these are the disadvantages. What is coroner's clot and what is its importance?
No idea, sir.
Anybody else
No, sir.
in the crowd who can answer this?
Is the eschar formation
Pardon?
is it the eschar formation formed after the
Eschar
tonsillectomy?
formation. They say coroner's clot. It's not, eschar means it's a dead tissue. What happens in
Yes, sir.
burns. But here, who is a coroner? All of you would have read forensic medicine, heard this terminology, coroner. It's a medical legal officer, isn't it? Who conducts a postmortem. He's called a coroner in
Postmortem.
British English. Okay. So in the olden days, they found that people who died after tonsillectomy had a clot in the nasopharynx which caused the obstruction to the air passage and caused the death of the patient. And it was found out in the postmortem. So a big clot in the nasopharynx obstructing the airway, and as you know, all children are preferential nose breathers. They breathe through the nose. The big clot will completely block the nasopharynx, and they don't know how to breathe through the mouth for a long time. So they develop respiratory arrest and die. This is of historical importance. Nowadays we don't see this because we are aware of this problem, and surgeons are also quite aware, and they do a good job of good hemostasis. So especially after adenoidectomy, there is a possibility of a big clot occurring in the nasopharynx, and this may cause obstruction in the post-recovery period. So the importance is for all adenotonsillectomy or oral surgeries, it is the duty of the anesthesiologist to visualize the oral cavity for any clot formation or residual clot lying there by using a laryngoscopic vision. So you have to put a laryngoscope and visualize the oropharynx. And if there is a nasal clot formation, it will be seen behind the uvula, just trying to come into the oropharynx. So you must suck out all that clot and clear the airway before you extubate the patient. So that is the importance of this coroner's clot. What is the post-op management of post-tonsillectomy patient? What are all the important things that you have to take care of?
We have to watch for any bleeding, sir, and we have to keep the
Regular.
baby.
I'm not talking about the post-tonsillectomy bleed question here. Any regular tonsillectomy patient, what are the post-op care that you should offer?
We have to keep the baby in the recovery positions.
What is that position called?
Sir, in the left lateral position with head down and a shoulder, a rolled cloth under the shoulder to keep the head down positions.
So it
So
is
the-
called the post-tonsillectomy position to prevent any aspiration happening and any small bleeding will come out of the oral cavity without getting aspirated or followed. Okay, so that is the first and foremost thing. Post-tonsillectomy position should be adopted, number one. Then, what are all the other things that you have to take care of? Will there be pain?
yes, sir.
So, what are all the methods of abolishing the post-tonsillectomy pain?
Can give intravenous NSAIDs and opioids and paracetamol.
Opioids are safe for post-tonsillectomy, the oral surgery, and any obstruction in the oral cavity or tongue falling back may be disastrous here. So better to go for opioid-free analgesia, okay, or opioid-sparing analgesia like paracetamol, either by rectal suppository or by intravenous route. NSAIDs, you can give magnesium, you can give lignocaine. Any local blocks, filtration blocks that can be used for both intra and post-operative pain relief.
Yes, sir. Infiltrating the local anesthesia between the anterior pillar and the.
So what nerve do you block there? What is it? Any block you must mention specifically which are the nerves that are blocked. Ascending palatine and pharyngeal nerve blocks. Okay, they are called ascending palatine and pharyngeal nerve block. And the application of 4% xylocaine to the tonsillar bed after dissection of the tonsil. All these things are the methods of achieving local anesthetic pain relief. What are the possible complications after tonsillectomy?
Pain, bronchospasm, and
Bronchospasm
respiratory
or
obstruction,
laryngospasm?
laryngospasm,
Laryngospasm is more common. Why laryngospasm is more common? And what are the conditions which can trigger a laryngospasm?
So trickling of secretion into the larynx will trigger laryngospasms.
Okay. Will every person get a laryngospasm?
No, sir. The patient who has recovered from anesthesia and who has the cough reflex and.
Will they have laryngospasm or no laryngospasm? A patient who has recovered and has a good cough reflex, will they have laryngospasm or no laryngospasm?
They will not have
They will
laryngospasm.
not have laryngospasm. Only a partially recovered patient will have laryngospasm because their conscious level is not complete to protect their airway. Okay, so a semi-recovered or a partially recovered consciousness with a trickling of saliva or blood approaching the laryngeal inlet triggers a laryngospasm because it is a protective reflex not to allow the exogenous substances to get into the trachea. Okay.
Yes, sir.
So semi-conscious state. So either patient should be deep enough or it should be fully awake. These are the two conditions in which laryngospasm will not happen. So if laryngospasm has happened, how do you identify that? What are all the different degrees of laryngospasm? This is a very common question, especially in pediatric cases after tonsillectomy. In the exam, they ask you this question very, very repeatedly.
There will be inspiratory stridor.
Stridor, very good. Exactly the term that we have to use. There will be stridor. So how do you define stridor? What is the definition of stridor?
It is the turbulent flow of air through a narrowed Uh,
Passage.
respiratory pathway. Passage.
Okay, that's partially acceptable, but it's a harsh vibratory sound due to partial obstruction of the airway. That is a better definition than the turbulent flow and all that. It's a harsh vibratory sound produced by airflow through a obstructed airway. That is called stridor. So if a stridor is present, is it good sign or bad sign? And a child not having a stridor, another child but getting desaturated, another child having stridor but may slowly desaturating. Which child is safer?
A child with stridors, because there is only partial
Excellent.
spasm.
So if the child is totally spasm, gone into spasm with both the vocal cords in complete adduction, there will be no noise and no breathing, and it will be there a severe indrawing of the supraspinal notch will be there, and patient will desaturate. And what can happen in a pediatric case if they desaturate?
Bradycardia.
Bradycardia and arrest. So they go for, why they go for bradycardia and arrest compared to an adult? And they develop hypoxia. Because what is the autonomic nervous system development? Do they have equal proportions of both parasympathetic and sympathetic, which is dominant in pediatric patients?
Parasympathetic is dominant, where sympathetic will
Parasympathetic
be
more
immature.
prominent. So the sympathetic system will not come to help. So patients develop bradycardia and arrest if they develop hypoxia. Okay. So that is these are the questions that you should expect in the exam. Post extubation problems like stridor, laryngospasm. So how do you manage a laryngospasm? It is partial and if it is complete. What is the method of
So
management?
if it is partial, we can ventilate the baby. Like we can non-invasively ventilate the baby with a PEEP.
Positive
And we
pressure.
can provide 100% positive pressure ventilation with 100% oxygen. Sir.
Very good. Then
If
Which
it
are
is
the only-
completely, sir, there is
that is one
complete
method.
obstruction.
No, for partial obstruction, is there any other thing that you can do apart from positive pressure ventilation with PEEP, 100% oxygen?
Can manually
And-
give PEEP by doing Larson's maneuvers.
Larson's maneuver, yes, that is another very, very effective method in partial obstruction. Larson's maneuver will help to relieve the spasm. Anything else?
First is
Third option.
removal of the triggering stimulus.
That is the suction that you can put. Any other intravenous drug that you can administer to relieve the spasm?
False.
Succinylcholine.
10 to 20 milligrams of propofol, not the usual induction dose, but 10 to 20 milligrams of propofol can be given, which will obtain the reflexes and it will relieve the laryngospasm. So three things you have to remember. One is good mask fit and positive pressure ventilation with 100% oxygen, Larson's maneuver, and small dose of propofol IV. All these things will help to relieve partial laryngospasm. But if it is a total laryngospasm with no air entry at all,
We have to give
The patient.
muscle relaxant. We have to
say specifically what muscle relaxant. Can you give cisatripodium? Succinylcholine. That is the answer. You must specifically mention the drug name. So you
Yes.
can give partial dose of succinylcholine, not the intubating dose, but 0.5 milligram per kg of succinylcholine IV can be given to relieve total complete laryngospasm. Okay, these are all the answers which should be very, very thorough in your exam because they commonly ask you all these points. Now, what is stridor? What causes stridor? How to manage? We have seen that. What local anesthetic blocks are used for pain relief after tonsillectomy? That also we have discussed. What is the preferred route of intubation? That also we have seen. What is the alternate for EP intubation and what are its advantages? which is very common in UK and the Western countries. They prefer this for tonsillectomy rather than endotracheal intubation.
Laryngeal mask airways.
Huh?
Laryngeal mask airways.
What type of laryngeal mask airway? You guessed it right. What special type of laryngeal mask airway you can use?
Second generation with a gastric port.
Elective procedure, starved patient,
Eye gels.
flexometallic laryngeal mask airway. Because you know the tube has to bend according to the mouth gag configuration. So now Western countries they regularly use the flexometallic laryngeal mask airway for tonsillectomies. The advantages are doesn't cause any irritation, no laryngospasm. The
Can
patient
avoid
can
muscle relaxation.
breathe smoothly post-operatively until the patient is fully awake. You can retain that and then pull it out later. Okay, so these are all the advantages of the tonsillectomy. So that finishes the discussion on post-tonsillectomy bleed.